Hi, everybody. Welcome to our September speaker series. My name is Melanie Camuesa. I work here at the foundation. I'm the Research and Global Health Manager. Um, and today we'll have Dr. Aaron Zelikovich, who is a neuromuscular attending now for the speaker series. I would like to thank our sponsors and yes, sorry guys. Today we'll be focusing on the topic. If you are looking for further information outside of this topic, send us a message or an email so we can point you in the right direction. Dr. Aaron Zelikovich recently, as I said, recently finished his fellowship training in neuromuscular diseases and joined a group of young healthcare professionals and emerging faculty at the symposium. Dr. Zelikovich will recap some of the things he learned from his session and share this information, share some of his favorite moments in this session. Okay, and before we start asking questions, it is just a brief reminder that these webinars are meant to be educational and not meant to troubleshoot or consult individual cases. As always, talk to your doctor about your care. If you have a question about the topic we are discussing today, please type it in the Q&A box below. But again, remember that we won't be troubleshooting specific circumstances or answering questions about specific medications you are taking, etc. All right. Um, I'm going to um, stop sharing my screen. So sorry. Okay. All right. So we'll just get right into it. Dr. Aaron, can you briefly introduce yourself and share your professional background with us?
Absolutely, Melanie. Thank you so much, everyone today who's joining on this webinar. It's really exciting to both be able to recap kind of my experience at the GBS-CIDP Foundation meeting, as well as get to learn from all of you. And I know that you guys, the community in the GBS-CIDP Foundation world, has such great questions. And even throughout that weekend, I got so many great ones. So I'm hoping it'll be a little bit more interactive, and definitely be sure to use the chat feature because I would love to hear from all of you who are participating from today as well. My name is Aaron Zelikovich. I'm a new neuromuscular trained physician. So when I applied for this opportunity, I was actually a neuromuscular medicine fellow at the University of Pennsylvania. Mel and I were actually just talking in terms of all of the historical people that were so crucial in identifying CIDP, identifying treatments for CIDP and GBS. Really, a lot of them were at Penn. So being able to train there as a fellow under Dr. Sean Bird, under Dr. Shafiq Karam, and many others there as well, Dr. Sami Kella, who was actually at the meeting too. It was a really unique opportunity and really made me who I am today in a sense. For many residents in neurology, you see Guillain-Barré in the hospital. You probably see a couple a year, but you really don't get to understand how patients with Guillain-Barré syndrome go into the outpatient setting, right? Because a lot of our time as residents, we do inpatient or inside the hospital. So my fellowship experience really allowed me to get an understanding of the complexity of care that is required for patients with both long-term symptoms with Guillain-Barré, as well as those that transition to becoming CIDP or more of a long-term neuropathy and kind of the symptoms with that. My original background in neuromuscular medicine was actually on therapies for spinal muscular atrophy. So I first started in 2013, which is kind of crazy to think about, almost 11 years that I've been working in the neuromuscular sphere. And my passions through neuromuscular have changed. Initially, I was pediatrics, now I'm more focused on adults. But my passion has remained the same in terms of my research goals and my clinical goals are getting
Mhm.
people walking more. So I'm really excited to learn more about the GBS and CIDP community. And one of the really cool projects I had at Penn was actually presented at the meeting. And it's something I know we'll talk a little bit about later today. But in short, I'm a neuromuscular attending who's really passionate about patients with various types of neuromuscular disorders and specifically with demyelinating neuropathies like Guillain-Barré and CIDP, and really finding treatments and opportunities to one, make people walk longer and to reduce the pain and all the symptoms associated with having GBS and CIDP. So I'm really excited to get to meet all of you and learn more about the community as well through this webinar.
Oh, that's wonderful, Dr. Aaron. I'm glad that you actually talked about a little bit about your passion. So, which brings us to our next question. What motivated you to pursue a career or healthcare career in neuromuscular medicine?
So it's all good stories. it had a twist. So my parents told me growing up I could be whatever I wanted, a doctor or a lawyer. My older sister ended up being the lawyer, so I had to be the doctor, right?
Of course.
So in undergrad, I was doing the pre-med track, was really unhappy. I was working in an oncology lab. It really wasn't a passion of mine. I did it, I was good at it, but it really didn't spark joy and passion that I really thought of a career. So my junior year of undergrad, I was looking for other alternatives. Unfortunately, things didn't work out, which was a blessing in the end because I ended up getting an email about an opportunity to work in a lab, a neuroscience lab that studied spinal muscular atrophy.
Oh,
Postdoc was really great. I enjoyed the project. And then I emailed Dr. Nancy Kuntz, who was my first mentor. Hey, I'm doing this really cool research in patients with SMA. Can I come shadow you? And it was my first time in a muscular dystrophy association clinic that I was like, aha, I can be doing this the rest of my career. So that's what sparked my interest in neuromuscular medicine. And I was actually able to work on three pivotal clinical trials that have revolutionized diseases. And we're
okay.
now talking about a different natural history for young kids with SMA who used to, have feeding tubes, breathing tubes,
Hmm.
pass away when they're really young, are now playing soccer, are developing within a normal milestone. So my hope is to be able to translate that into all different types of neuromuscular disorders, including the GBS-CIDP community, and getting people to be in remission and as little
Hmm.
symptoms as possible. So that's the ultimate goal and what continues to drive me every day of my clinical career.
Oh, that is wonderful to hear, Dr. Aaron. Inspiring stories. So ideally, that is also our goal here at the foundation is just to support our medical doctors and just support our patient community because ultimately the goal is to have a full life or quality of life. So I really hold that sentiment and relate with you in terms of just wanting to improve people's lives and trying to find ways to improve that. Um, yeah, and also, how did you get involved? How did you first get involved with the GBS-CIDP Foundation International?
Awesome. So, as in any good fellowship, when you see a patient, you ask questions. So, one of the patients we saw, without giving too much details or HIPAA, was, they'd come in, we newly diagnosed them with CIDP, and I was looking through their medical records, and it seemed like they had a Guillain-Barré syndrome about 15 years prior. So I asked Dr. Shafiq Karam, I was like, Dr. Karam, is this a known risk of CIDP, like a prior Guillain-Barré? It's very clear in the literature that some patients with CIDP actually present with acute Guillain-Barré
Hmm.
transition to CIDP, but there really wasn't any literature or data to suggest that a prior Guillain-Barré 15, 10 years ago, 20 years ago leads to increased risk of CIDP later down in their lifetime. So he said, that's a great question. As with all
Hmm.
how research starts, I started to try and answer that question. So we worked with Dr. Crum and my co-fellow Dr. Rebecca Shu, and
Hmm.
we created a Penn CIDP database.
Okay.
And Dr. Karaman mentioned to me, he's like, hey, this is really in line with what the GBS CIDP Foundation is working on in terms of understanding how patients are treated with the
Hmm.
EDA classification system. He's like, what if we create a database, you work on a project, and get more
Hmm.
involved in the GBS CIDP Foundation? So it's because of my mentor, Dr. Karam, who's actually, I believe, on the Global Medical Advisory Board and a
Yes.
close friend and mentor. He's like, this is a great organization. I think you would really love it. And your work really aligns with our mission too. So he encouraged me to apply for the grant and the
Yeah.
scholarship, which I'm very thankful for. And he really was the one who opened that door for me to be able to learn more about the foundation and also get to be a part of it now, which is really exciting.
That is great to hear. So I guess we'll just dive right into the symposium. So you got your scholarship, you applied and you received the scholarships, and you were talking to Dr. Karam, who's obviously attended our symposiums before. So what were your expectations going into the 2025 symposium, and how did that experience compare to your expectations?
So it's challenging, right? Because I consider myself a clinician, a scientist, and many of the meetings that I've been to in the past have been more scientifically focused. The thing that I can maybe compare it to a little bit, or kind of what expectations I had, was more of the MDA meeting or the Muscular Dystrophy Associating meeting that I
Mm-hmm.
went to, which tended to lean more heavily research pharmaceuticals, and less of the patient side. So it was really my first opportunity to go to a conference that was really dedicated to advocating for patients.
Hmm.
And to me, all my expectations were blown out of the water. I was telling Melanie a little earlier that I think sometimes as physicians and scientists, we work really hard. We try and answer questions. Many of the things we work on, unfortunately, don't end up working. And sometimes it's really nice to have a reminder of why you're doing it.
Mm.
And yes, the science is cool. Yes, it's nice to get grants. Yes, it's nice to get new treatments approved. But at the end of the day, it's the human part that really makes us keep working so hard. And to be able to see how engaged the CIDP Guillain-Barré syndrome community is heartwarming, right? It's the thing
Hmm.
that continues to fill your fuel tank. It's the thing when I'm in the hospital till 9 or 10 p.m. because, we had acute cases or something's really challenging.
Hmm.
It's those memories that say, okay, like this is why I'm working so hard. This is why we need to provide such excellent care because these patients really need it. And to be able to go to a conference that both balances the science, but
Hmm.
also the mental health needs, the pain needs, and the comprehensive care really blew me out of the water. I haven't seen a different foundation or event that I've been to so far that really focuses on the holistic care, both scientifically and also the mind as well. And I think I actually counsel all my patients like that. You have the brain, you have
Hmm.
the mind. If one is out of whack, the other one is going to be affected. So even if your nerves have healed, but you have processing issues or scared of having a relapse, your nervous system and your mind are going to be not working properly.
Hmm.
I think the GBS CIDP Foundation really has taken an active role in that. And, even Dr. Kellis talking about pain and the relationship with pain and long-term pain really shows the attention to detail that the foundation takes and the holistic approach for patients with this disease. And it's a model for all other foundations to kind of use going forward, I think.
Absolutely. So I guess we can just dive in a little bit. I know you just mentioned that how the patients being at the symposium and just hearing their perspectives and also the doctors. But I would like to dive a little bit deeper into how you felt the patient and caregiver voices at the symposium kind of shaped your perspective as now, I guess we can't call you young, you're a young healthcare professional, but as a new attending in the neuromuscular space.
Definitely. I forget his name, but I remember one of the patients who had acute Guillain-Barré
Mhm.
was talking about how, he quote unquote looks normal. He's walking
Mhm.
maybe a little bit slower. It's the guy that went to the football game, his name. But he really wanted to go to an LSU football game. And, he had to plan out his entire trip because he needed to take breaks. He needed
Mhm.
to make sure that he, wasn't in pain and, taking stairs at the stadium and,
Yeah.
mapping all of that out. So I think one of the things we forget as physicians and scientists is we see a patient in clinic, right? I do
Mhm.
your exam, I update your history, I update your medications, but I don't get to share your lived experience. And I think that's what a lot of times we forget. And it's very easy to say, here's your refill for IVIG,
Yes.
here's your gabapentin, or here's your duloxetine. But it's much harder to say, how are you doing day to day? What does your day to day look like? And I think that's what was so inspiring to me is to be able to hear patient experiences and stories and the challenges that they face, even though if you were to see them in the street, you wouldn't think twice if there's anything wrong with them.
Mhm.
Obviously, people who are in walking with canes or crutches or wheelchairs is a little bit different, but it was really surprising to me to see the challenges that these patients are facing and how much more we need to help the spectrum of patients with GBS and CIDP, even if they're quote unquote not active disease. And I think that was very humbling for me.
Very humbling. So I'm guessing that was one of your inspiring, eye-opening moments as well at the symposium.
Absolutely. One of many.
One of many. Well, I know you just mentioned a little bit about pain and Dr. Keller about the session on pain. So I was wondering if you would like to were you aware that that was a session that was going to be discussed in terms of just the management and or the medicine for GPS in terms of pain management? Could you share briefly about that discussion or that talk?
Absolutely. So I cheated just because Dr. Keller was one of my mentors and attendings, and he's
Okay.
fantastic. So I was very lucky in fellowship to get to listen to him teach.
Okay.
our lectures as well as in conferences as well that we hosted at our fellowship. So I
Hmm.
was able to see, oh, Dr. Hill is coming. Great. I'm definitely going to be at that talk.
Yeah.
So it was really incredible because, he really talked about the self-care aspect of pain, right? Obviously in acute Guillain-Barré, we understand that there's nerve damage and a lot of
Hmm.
things happening, but you really focus on the post-care, right? Like you no longer have acute Guillain-Barré or your CIDP is doing well, you're on good therapy, but you're still in a lot of pain. And really understanding that it's an adjustment period, right? What does this pain feel like? What is unique about this pain? What are things that are helping it? What are things that are not helping it? And it can be really overwhelming at times. And a lot of the patients on the panel provided their own insights and perspectives on it. And I think, I forget his name, but the chair of the medical advisory board or the patient advisory board, Kenneth, no, not Kenneth. I forget his name. He was talking about his typical CID pain felt different. And he's like, Doc, like something is weird here. Like, I know my CIDP pain, this just feels different. And he
Hmm.
mentioned publicly, he was really thankful because he spoke to his neurologist. Like, you're right, this does sound weird. This is not your typical pain. And he went to go get an MRI of his neck, and there's
Hmm.
actually a compression. And he went to go get surgery to fix it, which, if you thought that all pain is CIDP and you didn't know your own body pain, then he would have missed that and potentially lost ability to move his limbs. So I think it's really important that we both balance the need for resolution of pain, but
Hmm.
also the understanding of pain. And that's something that each individual can work on with a multitude of different health professionals. We talk about physical therapists, we talk about mental health counselors, we talk about massage therapists or acupuncture people. There's a really great variety of treatment modalities beyond medications. And that's
Yes.
why I always encourage my patients. I like to do both, right? I don't think you can have one without the other, and they're all tools in our toolkit. And that's what that panel really highlighted, especially the variety of experiences, right? Your experience with pain with GBS or CIDP is likely going to be different
Hmm.
than the other person sitting in the room. And that's what's really cool about what the foundation did, is it wasn't just like this is the prototypical CIDP patient or GBS patient, this is the experience, and that's it. And that's what we're catering towards. It really
Exactly.
did an amazing job at highlighting the variety and scope of what people experience. I think that's an amazing feature of the conference that I didn't expect, but I'm glad that it was a focus.
Okay. I would like to add to that, just in meeting patients at the symposium, and even with sitting in the GMAB one-on-ones, do you have any thoughts on patients who had GBS and then CIDP, or whether it was CIDP all along?
Yeah, so that is in question. Um, if I had the answer, I would become a professor tomorrow. That's unfortunately a really great question, and it's something we're actively working on.
Hmm.
I know Mayo Clinic, Penn is looking at all these things. I don't think we have a good biomarker for active disease now. And
Hmm.
we're not able to differentiate clinically the patients that appear as acute Guillain-Barré versus acute Guillain-Barré preparing for CIDP. The immune system is extremely complex. And I know one of the other medical advisory boards member kind of gave a patient-friendly talk about it and the complement cascade and the different antibodies that could potentially be involved. And I remember a patient asking, I have GM1 antibodies, but I was told I have CIDP and not MMN or multifocal motor neuropathy. And she's like, well, it's not so specific. It could be that. It could be that. We take the whole clinical picture.
Yes.
At this moment, we really can't differentiate. I'm hoping in the next decade or two, as we better understand how to characterize nerve damage in the peripheral nervous system, we'll get a better sense of here's a blood test. This is the odds that you will develop CIDP from Guillain-Barré or
Hmm.
not. And that's kind of a really cool research project that I assume people are working on. But if not, I'm happy to take that on and kind of see what we can do. But I think it's a really cool idea and a really cool topic and something that we really need to do for the community.
Okay. Well, since we are talking on the topic about research and the future, I was wondering if you could share any research updates or sessions that really surprised or excited you at the symposium or just in general in our GBS, CIDP, MMN. Um, world.
Absolutely. So I'm not an immunologist, so a lot of the immune stuff in terms of complement inhibition and other cascade pathways, um, I wouldn't do justice to it. So I kind of want to leave that to the side, but there's some really cool um, immune mediated targeted therapies that are being
Hmm.
studied, and I'm really excited about those. And I know my at Penn, we were able to participate at a lot of those clinical trials as well, which was fantastic. The thing that I thought was really interesting that, spoke volumes to me on many fronts is Dr. Allen's talk about the new evidence of disease activity scale.
Hmm.
For those of you who are not aware, one of the leadership council's kind of goals for the past years working with the foundation was to really understand how do patients communicate with physicians and vice versa, the status of their disease progression. So, right, like if you're having symptoms, does that mean your disease is active? Does that mean your disease is just not getting better? And it was a really challenging 2 years to be able to really come together as patients, physicians, and a community to try to start to define these criteria. And I think that Dr. Allen did a really good job in terms of synthesizing the logical step by step process that the foundation had in order to be able to create that. To me, what was the most inspiring part of it was the fact that it actually began with patient input. I don't remember the exact number of patients, but I think like 15 or 16 patients were actually brought together to describe their experience in navigating their GBS or CIDP story to be able to focus on language that was used. And I'm not here to say I'm the most well versed, amazing writer or master of language myself, but I also can appreciate that many of you on the call who are
Hmm.
patients with GBS or CIDP may have been frustrated with how your doctor was labeling your symptoms, your disease, and kind of your relationship with it. I don't know if this person's on the call, and I don't know if I can share this publicly, but I'll generalize it. In,
Yes.
in a sense, one of the patients came up to me from our research project about this and was kind of talking about he or she didn't have any symptoms. They're still on treatment because of
Hmm.
another disease that they couldn't go off treatment for it. And they're being told that by this new classification system, they're not remission off treatment. And I told them, I was like, you're right. We don't know, right? We don't have that answer to be able to do it. And it was really humbling for me in that perspective that how complex these situations are and how diverse this patient population is as well. And that's why when we're working on our database at Penn, we actually were able to do the first real life application from over 200 patients in our medical record and look at how this new classification system can be applied in the real world setting. And it's
Hmm.
a really great system, but there are limitations to it, as that patient kind of brought up. And as we go through these iterations, we're going to get better at being able to communicate both with other physicians, with patients, and really using language that allows patients to feel like they're in control of their disease and navigating it in a respectful, meaningful way that really doesn't put them in an uncomfortable situation, feeling like they're being dismissed or they're not being heard. And I think that's what I heard a lot at the conference, which was actually really heartwarming in the sense of these patients care and they're not just disillusioned and that they're standing up for what they want. And I think
Hmm.
that's what we need more in our community. And this is a great example of a foundation that really supports that.
Yes, absolutely. I think you were just describing a little bit of our leadership collaborative with, I think that's what you were definitely describing. So for those of you that don't know that, there was a leadership collaborative. It's on our website if you need more information. But as Dr. Erin did such a great job at describing what that was, it's just patient focused and defining symptoms and basically these GBS, CIDP, MMN patient journey, what that looks like from each stage for patients, and very patient focused. So essentially, our patients were the ones that were able to give us that feedback, as you said, that it is their journey and they know their disease better than anybody else. So that is definitely a great tool to have in this community. I did want to ask you also, were you able to attend the session on fatigue?
I think I was actually doing the GMAB one-to-one, so I don't think I attended the fatigue one.
Okay. And then would you like to share just a little bit about what you know or the understanding of fatigue in our patient community?
Yeah, totally. So fatigue is a really hard symptom in neuromuscular. in neurology as a whole. And the reason for that is it's non-specific. So, when I was in residency, we had these things called 28-hour shifts. I don't know if you guys are aware of them, but it's typically you start at 7 a.m., you're
Right.
on call for 24 hours at the hospital, and then you're there for 3 to 4 hours extra rounding on your patients, closing up everything. So I have fatigue after being up for 28 hours and working for 28 hours.
Mm-hmm.
So when you use that label, I can use it, but a patient with CIDP can also use it saying, hey, I'm tired. My muscles are not working. My nerves are not working. I feel
Mm-hmm.
fatigued. So as a neurologist, right, it's really hard because it's all subjective. I don't have a blood test. I don't have a nerve conduction study test that I can say, hey, your fatigue is not real
Mm-hmm.
because not that it's not real, that it's related to your sleep, that you didn't sleep well last night,
Mm-hmm.
or you're not eating well, you're not exercising well, or it's actually your GBS or your CIDP. Fatigue, for me, in a CIDP perspective, and I don't have any scientific data to support this, this is all just personal experience.
Mm-hmm.
I think it's multifactorial. One, I think that your nerves aren't working well. And if you're needing to expend extra energy to be able just to do the normal things, your body's going to feel fatigued. So that's one component of it. But we also know people who deal with anxiety, deal with depression. Why did I get CIDP? What did I do to deserve this? Why am I struggling? And, our friends in the CIDP community, only needing a cane and I need a wheelchair. There is a component of that as well, whether it's lack of access to mental health
Mm-hmm.
resources or lack of acknowledging it. There is that component of it as well. Then there's also a component of mood, right?
Mm-hmm.
It's sunny outside. You guys can kind of see the window and see it's really nice outside.
Yes.
I just feel better when it's sunny and nice outside and I feel less fatigued.
Yeah.
When it was cloudy and rainy yesterday, I felt tired. I didn't
Mm-hmm.
have as much energy. So, going back to what I said earlier, there's a lot to do with the mind and brain, right? If your mind's not doing well because it's cloudy outside, it's going to be harder for you to walk. It's going to be harder for you to navigate your pain. But if your CIDP is feeling better and you're on aggressive treatment and you're doing better, it's going to be easier to not feel fatigued because you're going to have more energy. It's going to be easier for you to walk. It's going to be easier for you to move. You're going to have less pain.
Mm-hmm.
And that's what can kind of help with fatigue. So personally, I think fatigue is a really underappreciated symptom in the sense that it's really hard to scientifically diagnose, and it's something that we don't have a good solution for, right? Having treatment for fatigue we don't have, and it's really hard to be able to treat it. So that's why I think it's really challenging for us as physicians to really clearly diagnose it and then give an effective treatment at this time.
Okay. Okay. Thank you very much for that insight, Dr. Aaron. I did want to also ask, other than the leadership collaborative sessions that you attended, and a couple of others, could you share two more sessions you attended? Just a brief summary of them, what they were about, and just to give us an overview of what that was like.
Absolutely. So I really appreciated one of the patients who shared her story. I think it was
Mhm.
Charisma.
Oh, yes.
To me, that was a really inspiring talk for multiple reasons. One, I think pictures say 1,000 words,
Hmm.
right? You see this healthy person who is peak of her life in high school, has so many dreams and aspirations, and her journey, right? We hear about being hospitalized. Thank God, like personally haven't experienced it, but when you see the picture and you see it humanizes the situation, right? It really makes it so that you can empathize and wow, what if I were in her shoes? And I think that no matter where you fall in the CIDP or GBS spectrum in terms of mild symptoms, severe symptoms, or in between,
Hmm.
all of the patients go through something similar. And to hear her story and the hope and inspiration she provided was really inspiring because she reframed the question from what can I not do to asking what can I do?
Hmm.
And it wasn't just a talk, it was an illustration. And to me, like that spoke volumes, and it was a really cool opportunity to kind of be a part of. The other sessions that I really liked were the wellness sessions, especially the Zen hallway and the other parts, because
Yes.
I thought it was a really good modeling of what you can do in the home environment, and to be able to take time, whether it's 20 minutes or 30 minutes, to really focus on your inner health is
Hmm.
something that was really cool to see and be a part of. So those are two ends of the spectrum, both the medical side and what it actually you go through, and then the mental health side as well, and how to really work on both of those.
Okay, wonderful. So for those that could not attend the symposium, what are two or three takeaways you would like them to know from this year's symposium?
That's really hard. Only two or three?
Well, if you have more, we'd love to
Okay.
hear.
One, I think the most important takeaway is how much the foundation cares about its patients and the research. It really is patient-centered, and it allows for all of you to have an active voice in it, both from going to conferences, advocating for different disease education awareness days, participating in your local community, and also coming together nationally as well and internationally now with all of the different initiatives as well, which is really cool. Two, I think the foundation reminded me to tell my patients that you're not alone. It is a rare disease relatively. I got to see many patients at Penn because we were a center of excellence, and an amazing center that people come from all over the region to see our attendings. But you're not alone, and I think being in a room of other people who have a shared experience is really beneficial, and something I recommend everyone to go to Boston in 2027 to really just being in a room of other people who it doesn't define them. They are living their best lives, and they're struggling through pain at days, and they're sometimes having difficulty or bad days walking, and that's okay. And
Hmm.
it normalizes the struggle that comes with CIDP and GBS that many people in the in the population that we live around don't really have that appreciation or understanding. And then three is the knowledge, right? You're when we're bringing in the medical advisory board, Dr. Allen, Dr. Karam, and everyone else, these are literally the people who are shaping the world of CIDP and GBS. And it's really cool to have had the opportunity to work under Dr. Karam, Dr. Bird, and Dr. Kella, but also to meet the other medical advisory board members. And I think, combining both the patient side in terms of the experience navigating the disease, but also having at the same time the world's experts in this disease, in the therapies, in the immunology and experiences that are being on the research side that's in a patient-friendly language is really nothing like anything else that you can get either in your local institution or without going to a national meeting like that. So I think those were the couple takeaways that I had that really have inspired me to become a better physician for people with GBS and CIDP.
Okay. Um, I can definitely relate to, well, I am not a medical professional, but this was also my first time coming to the symposium. So it's my first time as a new employee at the foundation. So definitely we always say this at the foundation that we do our work here so that nobody walks this journey alone. So ideally for me, that first time when we had our first timers coming in and you could feel the joy and the overwhelmness and the tears of joy and just for able to be seen. Oh my goodness, we are not alone in this thing. That's so frightening because imagine from the time of diagnosis when they hear like it's unknown, they don't know what they have. And then when they finally get the diagnosis and then it's like, well, who else has this? It's so rare. And then, so definitely love what we do here at the foundation. We also love what doctors like you are doing and just being involved and actually seeing patients as people first and not their disease. So definitely love that. Um, oh, did ask you, were there any sessions that you attended on any variants for GBS-CIDP? Any specific variants?
I don't believe so, but there was an interesting case. So I was able to sit on the Global Medical Advisory Board one-on-one sessions, which, if you
Mm-hmm.
haven't done in the past, highly recommend them. Um,
Okay.
and I can't go into specifics, obviously, for patient confidentiality, but it was really interesting to me to see sometimes how much there is a lack of access to good neuromuscular evaluation and care. And Dr. Diana Castro, who's in Texas, I believe,
Mm-hmm.
was
Yes.
really passionate about getting better access to people who needed questions to answer for their family members or themselves. And I think to me, it was really interesting to hear a couple stories of cases that didn't present in the typical way. And hearing what was done in terms of the workup was really eye-opening. Obviously, hindsight is 2020, and it's a lot easier to say, oh, I would have done that. But hearing the struggles that people have in terms of getting access to care when it's not classic, right?
Mm-hmm.
I think that's like the biggest thing that people don't really appreciate, right? Many patients with CIDP don't present in the typical case, or Guillain-Barré can be a little bit atypical. And that's when having access to people like Dr. Karam, Dr. Allen, Dr. Castro, and everyone else who are really experts in this is really crucial and beneficial when it's atypical. And I think that's what the foundation really is great at, connecting patients with the less traditional classic presentation and allowing them to ask questions, allowing them to get more information. What test would you have ordered? Should I get this test? Should I not?
Mm-hmm.
And that's something that was really insightful for me, and the opportunity to learn from all of the leaders in the field.
Okay. All right. Well, I'm going to switch a little bit of gears, just talking about personal growth and moving forward. How do you think attending the symposium will impact the way you care for patients with GBS, CIDP, or MMN?
Wow, so many ways. First, I think it was really cool to be able to meet other providers and other young healthcare professionals from around the world and really learn about how they're approaching Guillain-Barré and CIDP,
Mm-hmm.
and just learning from them and having a network. We were able to connect with our peers, and these are people who are going to be leaders in the field in the future. So it's really nice just to want to have a network of like-minded young professionals who are really dedicated to the GBS CIDP community. Two, I'm definitely going to be more careful on the language that I use. Sometimes I think that we use scientific language that
Mm-hmm.
one, patients can not understand, but two, patients may have a misunderstanding or misrepresentation of what you're actually trying to convey. And hearing about the EDA and the challenges that came about from the classification scheme, and all the patients who came up to my poster to talk to me about, this doesn't really fit my story. I think it's going to be a much more open-ended, where do you think you're at? What which one of these really resonates with your disease experience? And changing the conversation from you have this to saying, where are you at in your disease progression? Where do you feel we're going? Do you feel like you're at EDA1, EDA2? Are you at NEDA1? Well, we can go, I think all that information is on the GBS CIDP website, but it's really changing the way I start my interaction in terms of language. And I think that was really eye-opening to me, and something I really appreciated, because we get taught that in a little way in medical school and residency, but when you hear it from patients directly, it just changes the way you kind of approach things. And three, I think that we're learning that treatment for CIDP and GBS is not a one size fits all.
Mm-hmm.
I'm talking to different patients, different things worked for different people, and hearing their stories in terms of what worked and what didn't work will really allow me to keep an open mind in terms of sometimes having to be creative when the typical things aren't working, really working with a patient to better understand what their willingness to try different things are, and really working with them to get them as close to their normal or baseline as possible. And I think those are the major takeaways that I had.
Okay, great. That's wonderful. Um, so I think it may be a little bit repetitive. I just wanted you to probably just emphasize a little bit more on um, I know you just mentioned this, that it challenged your assumptions on about treating patients and supporting them with rare neuromuscular conditions, but could you just elaborate that a little bit more? I know you work in a neuromuscular clinic, so just kind of just give us a way of how that is attending the symposium and meeting as your patients come in and so forth, what that would look like for you just day to day on treating them.
Absolutely. So a lot of times getting to a diagnosis is really challenging. Many people in our system actually refer their patients who are questionable for second or third opinions to me. And it's really humbling because, they're great neurologists, but this is such a challenging diagnostic
Hmm.
disease that, I'm able to help navigate the patients and say, look, We're going to look at all your medical records. We're going to take it step by step. I'm going to spend as
Mhm.
much time as you need because I want you to understand why it's challenging. Because a lot of times we say, "Ha, you don't have CIDP, go home." And a
Yes.
lot of times say, like, this is CIDP, you need to start IVIG right away. But it's actually a lot more complex than that. And I don't expect any of my patients to have medical degrees or gone to residency or done fellowship, but it's also your body, right? It's your disease. And I want to make sure, and this is what the foundation really stresses, is an understanding.
Mhm.
Because when you understand why we're thinking what we're thinking, it no longer becomes a I'm telling you, it's we're in this together. And a lot of times, the challenging cases can be the most rewarding because you're working with a patient so closely, where it's not a go away, you don't have anything, I don't want to see you ever again. And it's also not, oh, this is easy, go get your IVIG, we'll see you in 6 months or 3 months, and that's
Mhm.
it. And it's those cases that the foundation really emphasizes in the sense of getting resources.
Yes.
Those situations that, you're on the borderline, like you don't technically meet criteria, but you seem like you have CIDP and you're not getting better and you're getting worse and you have a lot of pain. Who can we connect you with to see how we can help you? And that's, when you get to work with Dr. Castro, Dr. Karam, Dr. Allen, and everyone else on the medical advisory board, you see the importance of being innovative, thinking outside the box, really advocating for your patients. And to me, when you're the third or fourth provider seeing the patient, you can choose one of two things, right? You can either say, everyone's already seen them, they have nothing, what's the point? Or you can say, I understand you've seen many providers. We're going to put all that to the side. We're going to take a fresh look.
Mhm.
I think that's where I can provide a real benefit to patients and explain to them, this is why they were thinking this. This is why they kind of thought it was different here. When I'm looking at this test, this meets criteria, but this doesn't meet criteria. It's 50-50, right? It's something that could be, but might not be. And I've had a couple patients already in my career that they borderline, like they could have CIDP and there's evidence for it, but it's not clear cut. And to me, the foundation is what really taught me, and being at the symposium taught me it's okay to feel that way. And it's okay to be in this gray area and work with these patients to really help them because at the end of the day, it's not CIDP you're treating, it's patient XYZ.
Mhm.
And when you view it that way, it becomes a lot more rewarding and the relationship you have with your patient changes dramatically. And that's what I saw at the symposium and the foundation, and kind of the interactions that the providers had with their patients, and also the way the speakers were created. It really wasn't about CIDP. It actually
Mhm.
was more of a collection of individuals who had stories in their
Mhm.
CIDP journey. And I think that's what I'm going to be taking back away from the foundation's symposium.
Okay, great. And then just to tie in what you just said, did you learn anything at the symposium that would inspire advice for patients on how to communicate with their doctor?
Yes, multiple things, actually. One, I think sometimes it's important for patients to remember that not all neurologists and not all people that take care of patients with CIDP are comfortable with it. And I think that's something really important to appreciate, because if your neurologist or neuromuscular doctor doesn't feel comfortable, they what they're saying may come across as, not as helpful, but it's not because they don't want to be helpful. And I think sometimes it's understanding that when you're being treated by someone and you don't have that good relationship
Mhm.
and you're not trusting them, then sometimes it's okay to look for someone else to follow. Unfortunately, some people don't have that opportunity, but if you do, find someone you really trust. And I think that's what's really important to be able to navigate that. Two, don't be afraid to speak up. I think a lot of times, time is short. 20 or 30-minute blocks is not a lot of time to update your neurologist, do an
Mhm.
exam, talk about treatment options, and don't feel pressure to not say something. Always bring up symptoms and leave it to us to be able to navigate if this is really CIDP, if this is something else, or if I need to do additional tests to kind of figure it out. And three, kind of going along with, to advocate for yourself. Most neurologists, I can't speak on behalf of all, but many of us will respond positively to you advocating for yourself in a respectful way. Be like, hey, Dr. So and so, this is different. Something's off. I need to be seen. Can I be seen? And really knowing your body and helping us understand how your body's dealing with the disease. So I think that's what a lot of the people who actually were at the symposium already do. And I highly encourage all patients in the GBS CIDP community, whether you're with the foundation and involved or not, to really learn how to advocate for yourself. Because unfortunately, the health system we live in today doesn't allow for it normally. And sometimes patients really have to really advocate for themselves.
Okay, great. Awesome. Um, okay, so ideally, I would like to ask if you could summarize, well, this is a two-part question. If you could summarize your symposium experience with one word or phrase, what would that be and why? And also, how do you plan on staying engaged with the GBS-CIDP Foundation International community? Yeah.
So the word that I would choose is thankful, especially as a fellow and a young investigator. The opportunity that the scholarship and the foundation symposium attendance really afforded me is incredible, both from a empathy perspective, from a networking perspective, and also getting involved more in research perspective.
Mhm.
The patients there tell me more than I can learn in a textbook. The talks that I went to from both patients, advisors, and physicians taught me more than I learn in review articles. And it really inspired me. And I think that's where you don't get that seeing patients in clinic. You don't get that seeing going to medical conferences. It's really going to a conference where patient-centered experiences really in a big room with lots of people really can provide that. I'm really hopeful to stay involved with the foundation, both from a research perspective and also as a clinician. I'm really excited to partner with the GBS CIDP Foundation to work on our New York City based events. We're hopefully going to have a patient centered event in Staten Island and in Long Island as well. And we're hoping to partner with our institutions because we span the entire New York area to be able to provide whatever they need and to work with the organization to allow our patients to be connected as well as get resources for themselves as well in their home area. I'm also now referring all my patients I newly diagnosed with GBS and CIDP to the foundation to make sure that they're aware of all the resources and the community support, the events, and the social support that they have as well. And maybe one day I'll continue to grow, and who knows what it'll be. The future is hard to predict, but hopefully it'll be involving the GBS CIDP Foundation.
Yes, it's hard to predict, but we're very excited. It was a pleasure to have you at the foundation and just to get to know you just as a medical professional and just also as a person. So you're definitely wonderful. So
Thank
we'd like
you.
to keep you close to us and hopefully see you at the next symposium, definitely. So it's been a pleasure to hear from you, Dr. Aaron, definitely. So I think we're approaching we're here at our closing. If you have any final words or thoughts before we end the session, please.
Just want to say thank you to all the participants who joined today. I know it's a Friday morning or afternoon, depending on where you are. I really appreciate you taking your time to listen to me. Happy to connect offline. Reach out to the foundation if there's any questions or anything else you can help out, or if you're in the New York area and want to follow with me, I'm happy to see new patients as well as we build our program here at Lenox Hill Hospital in New York City.
All right. Thank you so much, Dr. Aaron. So we are going to um, close out this session. We just want to thank you for joining us. If you have more questions or need more support, please be sure to visit our website, send us an email, or give us a call. If you like this program, there are a few things you can do next. Please be sure to check out all of the resources on our website. We also have so many ways to raise awareness, whether by sharing your story or volunteering. Thank you so much, everybody, and have a wonderful day.